My mom is from Spain, and she always told me that every time that I have the opportunity to do a talk in my native language, I do it in that way. But I know that everybody do it in English, so we're going to share my English experience with all of you. Okay? So if there are some words that I maybe have to say in Spanish, sorry, especially I can translate jokes, so we have to work with that. I know it's really difficult to do that. There's all my disclosure, you know I have a daughter, so I have to work to get her to college. So what will be the objective for this afternoon? When I get the title, I say, okay, so you want to know what's happened with the co-infected population who is aging. So the first thing that we have to identify is what's happened, what is the effect of aging over HIV, then what is the effect of aging over hepatitis C, and after that, how is the effect of aging when the patient has both conditions. And of course, we're going to enter a little bit about what is the relation when we do some treatment on this patient, on this over 50-year-old patients. So what really is aging? And I know that could be hard for a lot of people to talk, but we have to remember something. There's inevitable. We're going to age. There's something that is irreversible damage to cells. And all depends if you are an angel or maybe you do whatever you do in your life, if you end at this lady who have only 42 years old, and you can see how pretty she looks, okay? That it maybe change the time of aging. It's like when patient ask me how long are you going to live, I say that is genetics, because you were going to long maybe the same time, the same year as your parents or your grandparents. But if you speed when you driving your car, if you drink a lot, if you smoke, you were going to decrease that lifespan. So again, aging is something that we can. It's reversible, it's inevitable. Oops. The definition from the census from aging is that older people, okay, is those who are over 55, okay, or the los maduritos, okay. So I'm not there yet. And the elderly are those who are 65, that the viejos, okay? So the viejo, and I said viejo with love, okay? But when we are going through the HIV era, that is completely different. Because for HIV patient, the definition of aging of all HIV patients, is 50-year-old. And what happened, why is that? Because when we start the epidemic, we never think that our patient were going to last up to 15 years old. So when you have a guy that was infected 21 years old, you know maybe at the beginning of the epidemic that is going to last 3 years, 4 years, 5 years. And that's why when we looked at HIV care many years ago, it's only based on change regimen, look how is the CD4, viral load, but we didn't look the complication. I remember in 2000, it's like when we really have to start to look, okay, patient are living a lot after 1996 change on regimen. We have very good regimen, patient lasts longer, so now there are more complications and there are more things related to age. And that will take us of what is the long-term survival. This is the data from the CDC to 2015. And the long-term survival in the United States, including Puerto Rico, is 47% of the patients are aging 50 or more. And most of those patients are on stage 3 AIDS. Remember, in the classification of HIV, when you get to the lower stage, you stay there no matter how good you are right now. It's like marriage. You make one mistake, they remember that forever. So exactly the same with HIV. But at that year, close to 3,000 patients who have diagnosis of AIDS also die. But maybe within, that's only happened because our patients getting old, that what we call the grading of the HIV area, not. Because we also have new diagnoses for patients who are over 50. And this is the data from the CDC in 2016, where 17% of the patients who was new diagnosed, that's means more than 4,000 patients, are over 50 years old. And 35% of them are on AIDS state when they arrive to clinic at the time of diagnosis. That's hitting a click to us right now. What is happening that our patients getting late on care. Data from specifically from Puerto Rico, this is the prevalence of Puerto Rico from people who was at the age of diagnosis. from the 81 to 2017. 253 patients, that means 12% of our population who has been diagnosed with HIV in Puerto Rico. The time of diagnosis was when they have 50 years or older. So what is really happening with our HIV aging population? First, we call that is the invisible population. And the reason for calling that is for us, guys. Not maybe for us, the ones who are here, because if we are here because we really care, but for most of the physicians, they don't like to ask about sexual practice of the patient, as Carlos already mentioned. They think that our patients who are over 50, over 60, they are not sexually active. And you remember after the blue pills, everyone is sexually active, so we have to think about that. And we are very good making jokes about sex, but it's really hard to talk seriously about sex. So it's really nice just to ask always about sex. I always teach my residents to say, are you sexually active? And smile. And then after that, boys, girls, and both. And then smile again. So you are openly asking the patient, you always assume that the patient is sexually active. Second, most of our physicians, they misdiagnose the HIV. Whatever sign symptom that is related to HIV, they are associated to any other disease. And that's happened, yes, Naira, that happened to all of us. They say, because after you do all the available tests and everything is negative, they say, well, let me do an HIV test. So it is really important that we think about that. Of course, patients usually don't know about HIV. As we mentioned, there's many years that people don't talk about HIV, especially in Puerto Rico, and the continental USA is exactly the same. Their condom use on the age over 50, they say, well, I'm not going to get pregnant, I'm not going to do, they don't think about STD, they think that there's something from the past. So they don't care to use protection. And there's also a big disparity between, especially at that age. But also, the other part of the invisible population are the same HIV patients. Why? They have a lot of psychological issues. And the biggest one right now is what is called the long-term survivor disorder, which is exactly the same as post-traumatic stress disorder. Those patients who have been living with HIV for more than 20 years, that when they start treatment, most of their friends die, when they're starting to taking just one medication, two medication, and they're trying to fight to get the medication. It's like when someone comes from war. Everybody that I love died there, and I'm always looking for what is happening. Maybe all those who come from war right now, they are in peace, but those who come from the HIV area, there's always looking, so what will be new? What will be the good thing that happened to me? We have excellent medication, but now I have with diabetes problem. Now I have gaining weight again. Then at the beginning I was losing weight, now I'm gaining weight. What is the reason? So they're still in that fighting mode. And also, they don't have usually the support that they need because all their best friends died many years ago. You also, for that reason, used to be in the loneliness area or try to make them isolated from the rest of the people. And even when they go to their physician, they didn't tell that they're HIV positive. They usually have just one physician who knows about HIV diagnosis, take care of the primary care physician or any other kind of specialty or specialty physician that sees the patient doesn't know about the diagnosis. So there's always a paradigm about is there really an increase of aging of HIV or not. And that comes from this specific reason. When you look at the HIV patient, what is happening right now in an HIV patient who has 50-year-old is the same that you see in a patient who is 70 years old but is HIV negative. So that was the reason at the beginning that we start to say there is an accelerated process of aging. And we have a lot of data regarding all the mitochondrial damage that is happening in the cells. All of you, I don't know, remember using the D drug, DDI, D4T, all this drug, all the mitochondrial damage that are responsible for the damage of the cell that are causing that kind of early aging. But also, okay, within, but maybe there's also an increased risk of that patient, and it's not that it's really an early aging, or maybe we are looking more on those patients that we didn't look on others. But as I joke say, maybe at your age, you're 95, maybe you will look nice. So that's what start to look. So what is really happening with this aging population? There's a lot of data right now. I didn't bring all of them because if not, the talk will be like the ATC talk, 3 hours. So it will be easier to show two different types of what we call aging. There's accelerated aging and there's accentuated aging. Accelerated aging is when something happens rapidly, more rapid than if you look, and accentuated is because having more amount that it happened in the other people at the same age. As you can see here regarding the cardiovascular complication, the point is here. That's right, good. That's a new thing, okay? This is accentuated because in both HIV negative and HIV positive is increasing. Of course, when they are close to 74 years old, there's also accentuated in those HIV patients. But when you look specifically in the bone problem, there is accentuated on females because you can see in both areas there's increase, but in male, there's accelerated because male usually have a decrease. Usually they're HIV negative, there's a decrease here, and those HIV positive are increasing. When we look more data regarding to that, this is 2014 data that show, you see the HIV positive are the orange color, blue color HIV negative. At the beginning of the age of the aging, that is when you are over 40, 50, 55, 59, up to 60, there almost be overlap one to other. But after 60 years, that's when you start to see the bigger part that is accentuated on the HIV different comorbidities. And why that happens? There's one man that I really love, and I wish one day I will going to talk with him faith by faith, that is Stephen Dick, okay? He started before 2010 talking about this problem of inflammation that is happening inside of the body, that is responsible for all those changes that we see on our HIV patient. And that's starting this way. When HIV patients get infected, we know when the virus gets to the body, they get in the first week, there will be a white powder, usually of small, the villi that are in the stomach area. And at the same time, that start to happen what is called the microbial translocation. And good explanation that something that be in your GI, in one specific area of your GI, go through another part of your GI or go to the bloodstream. That's not supposed to go there. And there's an increase of permeability, and for that reason, good things and bad things go back and forth in that area. And that is why there's an increase of inflammation. At the same time, the impact that have the HIV virus over the lymphoid tissue cause some damage and some fibrosis in the area. That same fibrosis is happening by the virus, caused by the virus to the liver. But at the same time, the microbial translocation also causes some inflammation directly to the liver. So now we are starting to make the sense between what is the real relation between HIV and hepatitis C and the aging process. So at the first point of the effect that we can see on that, there will be an increase on inflammation process. There will be, for that reason, there will be an increase on everything that is related to coagulation. I explained to my patient this inflammation process that is that if they have some lighter inside the vein, and that's what's doing the HIV virus, that causes this contact inflammation. At the middle of the process, of course, is what we see that is in the intermediate effect, is when maybe the first thing that we can see through lab is the arteriosclerosis process. That's why there's increase of cardiovascular problem. Also, there are some tissue necrosis that it is always associated with maybe the bone area, but there's a tissue necrosis in the renal part and also in other part of the body. And the distal effects of at the end, what is really happening is what we really call aging. So that's why the damage to the cell that happened really early at the beginning of the disease, that maybe that's why we talk so loud about start the rapid that you can, because we want to stop the virus to replicate. That's right. stopping the replication of the virus, there's some data that there will be decreased that kind of damage that is happening to the cell. Not to everyone, but it's some data that can prove that that happened. But that's what really happened to the cell. So all that aging process that is happening can be identified in patients in different ways. And that's what is called the geriatric syndrome that is common in all HIV patients. Of course, these geriatric syndromes are not specifically associated to our HIV patients. They're associated to all the patients who are aging. But of course, in HIV patient, and this data is specific for HIV patient, you can see there's an increase of frailty, and even the pre-frailty, okay, is found in 55% of the patient. So there are things that we have to look through our patients. So that's why someone said that you can see an HIV patient just in 15 minutes, and Carlos said that we didn't talk to our patient enough. Not every HIV, non-HIV patient also prevention. Tell me what time we have to talk about, because we have also to look about all those things in our HIV patient. So what is the really effect that have aging over HIV? First, there will be a blunt of the immune response, and for that reason, an NANCOR will give a big data regarding to that. There will be a less increase, so there will be a shorter increase on CD4 compared to younger patients, but they're not effect on the viral load. So if you go to the pretest, because it's a basic test question, is what is the difference between a geriatric and adult and non-geriatric patient regarding viral load CD4, is that geriatric patients usually have higher viral gets higher to non-detectable, very easy, and the problem is in the CD4, not in the viral load. So regarding to treatment, also based on the damage that is happening in the system, it's very important to start treatment as soon as possible. That shows here in the SMART study that when you have patients who are over 50 and have deferred treatment, they have the worst complications. So we need to start treatment as soon as possible. And the good is that the high virologic response that we have on those patients compared to the young. Also, when we start treatment on our HIV patient, the aging affects the process of metabolize the medication. There will be a decrease in phase 1 of drug metabolism, so that's really important, and also a decrease on the P450 activity. So we know that most of the HIV medication go through that. Most of our patients have used more than one medication for other conditions, that there will be a high probability of drug overdose. So that's why we have to look very close in our patients. Multimorbidity is something that we're going to find in our patient, and the reason for that related to aging is that HIV by itself, we're going to increase some risk of that. And the aging process just we're going to add more to increase the probability to clinical progression to AIDS. That's why, again, we better start our patient. Even when we look to the guideline, we can see that one of the reasons to start earlier patient is an older patient. So when we are going now, what is happening? What is the effect of aging over hepatitis C? First, when we see an elderly patient that, as other speaker mentioned, there's a high population who is elderly in the monoinfected hepatitis C patient. There's always an advanced liver disease. Also, there's an increased duration of the infection. Most of them have been infected for more than 20 years and never received any kind of treatment. They usually have higher viral load. Higher viral load is more damage to the liver cell. They have an increased rate of disease progression. And even there's some data that prove that in young patients who have hepatitis C, chronic hepatitis C, they present with cognitive impairment. So when we have hepatitis C in the monoinfected patient, the aging process affects an increase with cirrhosis. There will be an increase of hepatocellular carcinoma, and there also will be a reduction on an immune function based on the decrease of the telomere. The telomere, which is something that we rarely talk in HIV area, and it's really important, is the top part of the chromosomes, which is here. This is the young one. You see the red part, which is large, and you see the old one, which is small. Telomere are the part of the cell, the genetic cell, that are related to the aging process. And there is some data that even some medication could affect the telomerase, so they affecting the telomerase, that we're going to cause a bigger degeneration of that area. So there's something that is not only affected to hepatitis C patients, mono-infected, but also affected HIV patients. Okay? There's a condition or symptom called liver, the aging of the liver, which is the responsible of the progression of the cirrhosis, and is related first to increase of oxidative stress. So whatever is happening to for the patient, that means is they take a lot of alcohol, is they take a lot of even vitamins, or a lot of acetaminophen that they take it, they will have a lot of inflammation in the liver. The rate of hepatic flow is usually low, and when there's low, that means that there's a lot of toxins that stay there, and for that reason cause more toxicity to the liver. There's also a decrease in mitochondrial capacity. There's a higher prevalence of a genotype 1 that we know that have more damage to the liver. There's also increase of viral load, and the liver volume when the patient gets older is getting smaller inside. Smaller liver inside, there will be less capacity to function. Okay, so talking now about our co-infected patient. Co-infection happen based on HIV mode of infection. We usually think about HIV drug user, but we have to keep in mind, especially on MSN. This is the data from the different outbreak that has been on MSN, HIV positive around the world for hepatitis C. As you can see, there are several reasons when they get infected for hepatitis C. I remember one of my patients in my clinic in San Juan get infected based on empathy with using different kind of sexual toys and get infected with hepatitis C after being non-detectable on HIV and stable for many years. So we have to look for that in our patients. Okay? Usually, if we join what I mentioned before, there will be a reduction of CD4 recovery based if you have hepatitis C and HIV, and you will going to find a higher hepatitis C level in this also co-infected patient. But what are we going to find in co-infected patient? There will be a higher morbidity and mortality rate. As you can see in the table, comparing hepatitis negative, all that HIV, all patients, hepatitis C positive, hepatitis C negative, all those causes of death related to the liver, how big it is in patients who are hepatitis C positive. Also, in patients even younger, there will be more advanced fibrosis process. And we know more fibrosis, more damage, less ability to metabolize, not only HIV medication, all other medication that usually the patient have to use for the long of their life. And on those who are co-infected with hepatitis C and HIV, the cirrhosis happens 10 to 20 times that those who are non-infected, and hepatocellular carcinoma happens 5 times than those who are younger and are non-infected. So there's also a decrease of survival after liver transplant. Liver transplant is really something that is possible. I have already 2 patients that are co-infected with hepatitis C that have liver transplant and they're doing well, but it's not what statistics usually say on these patients. And why that happened? Exactly for the same reason. But now, when we have hepatitis C, we have another virus that also have a direct effect, attack to the liver cells that it will be responsible also for another additional damage. But the joint between hepatitis C and HIV together as a virus cause a bigger problem also in the GI tract and also in the lymphoid tissue. So again, the microbial translocation is worse, and that's why we have sometimes worse outcome on those patients. So when we talk about treatment on our co-infected population, the first thing that we have to know is right now all the new drugs are really good, and the result at the end to sustain virological response is exactly the same in co-infected and non-infected patients. So we can use it. And many years ago, we don't have to wait until patients have more than 200 CD4 to start that treatment. We can do with less than 200 CD4 cells, and there will be no problem. Even there will be a lot of data, not only in clinical trial, but also in real-world clinical cohort that show how good are those medications right now to treat co-infected patients. And right now, as Kolgi say, there's HIV infection is no longer a marker for lowest rate hepatitis C cure. I remember many years ago having fight because there's one medication for treating hepatitis C that doesn't have any kind of study with co-infected patients. Say, well, I'm not treating the HIV, I'm treating the hepatitis C with that medication. It's like, I don't need study with Crestor in HIV patient to treat this lipidemia. So it's really important that even if we don't have specific study, we have to look for the condition that we have to treat, and also we just have to look for drug-to-drug interaction or other possible metabolic complications that could happen. So if we're going to summarize what is happening really regarding co-infection in treatment, first, hepatitis C co-infected patient, the treatment is similar among infected. There's no different. Second, older patient will going to be treated as a young patient. No different. And of course, those who are co-infected have the same sustained virological response as those who are non-infected and those who are young. So again, we can give treatment without problem. And we have the availability of treatment, very important to use it. Okay? But before starting treatment, what is the clue? What is the thing that we have to look? First, all the comorbid conditions that our patient has. We have to look for all the possible adverse events that we could have for the medication that patients are using right now, adding now the medication for treat hepatitis C, and also the medication that have for HIV. Here is a website that can help a lot, the hepcdruginteraction.org. There's no way that we know all that, but we can look at that website, we put all the information, and you will get to know what is the relationship of possible drug interaction. I love to use that, especially when I have to ask for a pre-approval with a health insurance, and I want to use one specific medication, and they didn't want it. I send a copy of that, say that maybe there will be interaction for the medication that you want, and the one who see that in the health insurance say, okay, we're going to cover the one that you want. So it's a good tool. And we have to remember always, aging has some changes in pharmacodynamic and pharmacokinetic process. So we have to look what is really happening in the liver, in the GI, and the renal part of our patients. So I have some data regarding the co-infected treatment of patients who belong to ADAP. It's just that patient in that area. Up to May 20, 2019, 73% of the patients that have received treatment are over 50. Okay, this is the only data that I get. I asked for that, it's the only that I get, but that is a good thing that we have in Puerto Rico. Maybe compared to other places, ADAP program cover Hep C treatment for those who are co-infected. Okay, there's a long process like everything in the life. But there's a big opportunity that we have for our patients. So prevention and maintenance is something that is really, really important. And the first thing that we have to do is evaluate the alcohol use. And remember, whatever your Puerto Rican patient tell you that drink, you multiply that twice, 2 times. Okay, they I only drink 2 drinks. You drink 4. And there's a table there, there's a diagram there that shows how much is one standard drink. And if you compare that with what you drink last night or at the cocktail hour, maybe you were going to feel bad with yourself. So also there's really important that we evaluate for liver fibrosis and hepatocellular carcinoma. I have to emphasize, if you have hepatitis B, it's very important that every 6 to 12 months have your liver sonogram. Hepatitis C has oncogenic part, so the rate for change for a good liver to cancer, it could happen in 5 years. And there's a big sue if you don't do that. Hepatitis C is longer. The time to get to hepatocellular carcinoma could take 20 years after cirrhosis. So again, but we have to anyway evaluate what is the fibrosis and how is our liver. Also, it's important to evaluate the use of acetaminophen, and why I mentioned specifically that, because all patients resolve everything with Tylenol. And Tylenol is one of the worst medication to the liver. Okay, so we have to explain that to our patient and also to whatever other hepatooffender drugs. and provide hepatitis A or B vaccine is needed, and important, educate about prevention to transmit hepatitis C to other people. So everything that happened in the older age is more related to the inflammation process, and HIV is an inflammation process. So what else we can do to help our patient in inflammation? This is what I tell to my patient. I try to look for. First, adherence to treatment. Second, quit smoking. Then have a healthy life. Try to do exercise. I better use this slide that I love that say my well-being list. I tell to my patient usually to daily to look if they really have good food in the refrigerator, if they sleep well, if they can do more exercise. Of course, if there's smoke, stop smoking. Second, do something new always, every day. Maybe something simple like if you are right-handed, use your left-handed to brush your teeth. Okay? And weekly, stop smoking. Monday is the best day to stop smoking. Second, take your weight every week, not every day, every week. Plan something to do that is different on the weekend, that have some activity, especially outside. One of my principal offices in Ponce, there's an outside area beautiful to you can go. Of course, San Juan, Puerto Rico has many beautiful places that you can go. And of course, what is the last thing that you do for a good friend? Older people is getting along, so look for another friend and help your friend. Every 3 months, check your vitals, do your blood work, go to see your physician. Remember, we have to see our physician more often. If you didn't quit smoking, start quit smoking. As you can be, I can emphasize more how worse is the smoking for HIV patient. Okay? Look for your finance. Most of our HIV aging patients have a lot of finance problems just for they didn't look for that. And evaluate how you feel, how you doing. Are you big grumpy all the day? Maybe you didn't notice, but other people tell you that you have been grumpy. So look for that. Okay? And conclusion, and I finish on time, I can't believe it. For the HIV and also the hepatitis C population are getting older, as all we are. Okay? And liver is the major target for all that aging process. That's why we have to take good care of the liver. There will be multi-mechanism to that damage happen, but it's really important that one of the things that we can do to prevent that is in our co-infected patient, treat our co-infected patient. We know that it's possible to cure hepatitis C. So it's really important that we bring the treatment of our patient because the result is really good. Okay, so thank you very much. It's a pleasure to be here, and next.